Nick Majerison here, welcome to Top Med Talk. Today's Top Med Talk is called Obstructive Sleep Apnea. Snoring is boring and can seriously damage your health. It's presented by Andrew Spector, Assistant Professor of Neurology at Duke University Medical Centre in Durham. And it deals with standing up an obstructive sleep apnea clinic at your practice. It's a fascinating piece. It's divided into two parts. This is part one. Part two will follow tomorrow. Have a little listen, and I'll give you some words at the end.
Top Med Talk.
Finishing the day for us, we have Dr. Andrew Spector. He is an assistant professor of neurology at Duke, and he's the director of the Perioperative Obstructive Sleep Apnea Clinic there at Duke. And I had an opportunity to sit down with him on Top Med Talk just a little bit earlier and talk about all the amazing things that he's doing right now in that space of obstructive sleep apnea that really is kind of a new, novel idea for many of us on the front lines, and including that in our pre-assessment area. So, Dr. Spector, I'm going to let you go ahead and get started here. And
Thank you very much. So I'm going to talk about perioperative sleep apnea management, and we are building this at Duke right now. So we'll talk about the Duke experience and then how to develop it at your institution. This picture here is a picture of the Fat Boy by name, and this comes from the Pickwick Papers by Charles Dickens. And I included this picture specifically because my wife said I don't have enough pictures in my slides. So I figured what better picture of sleep apnea than one of the early depictions of your stereotypical sleep apnea patient. We're going to talk a little bit about why we probably shouldn't fall into the cognitive bias of assuming this is what all of your sleep apnea patients are going to look like. I have no disclosures. My objectives for today are to talk about your medical motivation for why we're putting emphasis on diagnosing and treating sleep apnea in the perioperative setting, to explore the challenges and difficult decisions that arise while creating a perioperative sleep clinic, and then the financial considerations of the sleep clinic that we're developing. So first half is going to be the why. That's what we're going to start with. Why are we doing this? And to make sure we're all on the same page, let's talk about what a perioperative sleep apnea clinic can do. Well, they can screen for sleep apnea prior to surgery, counsel patients about increased risk of surgery due to sleep apnea, counsel about the long-term consequences of sleep apnea even beyond the perioperative setting, initiate treatment for sleep apnea prior to surgery, ensure inpatient and surgical teams know the diagnosis of sleep apnea ahead of time so that the patients can be managed appropriately, and provide initial follow-up for CPAP post-op. What we're actually doing now is a limited selection of what can be done, and this is probably what's going on in most of the institutions around the country. Screening for sleep apnea perioperatively and preoperatively, I think, is relatively common. Notifying the anesthesiologist that this is a patient who might be at high risk, and then managing with increased monitoring, maybe reducing opiates or other respiratory suppressing medications. And that's about as far as I think a lot of places are going right now. So there's a gap between where we could be and what we're currently doing. And to help fill that gap, in 2016, the Society of Anesthesia and Sleep Medicine came out with guidelines on preoperative screening and assessment of adult patients with obstructive sleep apnea. So there were a whole bunch of guidelines in here. We're not going to talk about all of them. I distilled them down into some important ones that I wanted to talk about. First, they say that patients with a diagnosis of sleep apnea should be considered at increased risk for perioperative complications. And adult patients at risk for sleep apnea should be identified before surgery. All providers should be aware of the diagnosis of sleep apnea. And then this fourth one that I highlighted is CPAP or BiPAP should be available and used perioperatively. And I think this is the biggest one that we're failing to meet right now. And this is one of the guidelines that we're striving to reach. But is this worthwhile? Why are we doing this? So to figure out if it's worthwhile, I think we have to answer these four questions. Number one, does sleep apnea affect surgical outcomes? And number two, does treating sleep apnea affect surgical outcomes? Because if we know that it makes you worse but we can't do anything about it, it's less critical to identify. Third, does treating sleep apnea in the perioperative setting lead to long-term health improvements for patients? And then fourth, is perioperative sleep management feasible and cost-effective? We've got to be rational about how we do this. So to answer the question, does obstructive sleep apnea affect surgical outcomes? We have this great review article asking the question, does obstructive sleep apnea influence perioperative outcomes? So they actually looked at this very question. And they had about the largest sample of patients I've ever seen in a trial. There were 413,000 sleep apnea patients and 8.5 million in this meta-analysis. I've never seen anything with 8.5 million patients in a meta-analysis. And most of the studies included did show worse outcomes with higher complication rates. They didn't show a mortality impact of sleep apnea, and possibly it's because we're really good at keeping people alive, but it doesn't mean we want to have all of the complications that could arise. The next few slides go over some of the individual studies contained in the meta-analysis to show you more specifically what they were seeing. So this study, Seat et al., showed a high stop-bang score correlates to higher risk of, quote, unexpected intraoperative and early postoperative adverse events. Now, stop-bang is a questionnaire that we use to screen for the likelihood of sleep apnea, and it's a 0 to 8-point scale. So each letter of the acronym stands for one aspect of sleep apnea. So it's snoring, tired, observed apneas, high blood pressure, BMI, age, neck circumference, and gender. And you get a point for each of those risk factors towards sleep apnea. And if you have a score of 0, you're not terribly likely to have sleep apnea. And compared to a score of 0, those with stop-bang scores of 5 or even greater than 6 have an odds ratio of about 6 times of an unexpected intra-op or early post-op adverse event. So it's a massive risk factor. In this study, 1 million patients had elective surgery and were monitored for sleep-disordered breathing, and they had higher risk of emergent intubation, non-invasive ventilation, and atrial fibrillation. So again, we see a lot of cardiopulmonary adverse events from sleep apnea in the perioperative setting. So I showed you the meta-analysis and 2 sample studies, but there's more that we're not going to go into today in the interest of time. But the bottom line is, yes, sleep apnea does affect perioperative outcomes. Next question, though, is can we do anything about that? Can we improve these outcomes with treatment? For that, we looked to this study. Mutter et al. Reviewed 21 years of surgical data in Manitoba, compared patients diagnosed with sleep apnea after surgery to those who were diagnosed and treated before surgery. And what they showed is that cardiac arrest and shock were less likely in the treated group. And in this study out of the state of Michigan, 27,000 patients were divided into the groups with no sleep apnea, untreated sleep apnea, or treated sleep apnea. And the treated sleep apnea group actually looked just like the no sleep apnea group. So if you treated it, they had the same rates of cardiopulmonary complications, and that included post-op MI, and unplanned reintubation, and cardiac arrest. And those 3 were much higher likelihood in the untreated sleep apnea group, but not the treated sleep apnea group. So again, are there improvements with treatment? Yes, that's been clear throughout the literature that not only is this a major risk for complications, but we can do something about it. The next question is, does identifying sleep apnea perioperatively improve long-term health outcomes? And it turns out no one has ever looked at that question, at least no study that I could find, and possibly because the perioperative sleep apnea management is a new field, so there isn't a study of long-term outcomes from what we're doing. But we do know that CPAP has long-term benefits, and we don't have to look at just the perioperative world. We know that long-term use of CPAP helps. And so, for example, in this study, men, and specifically men, without sleep apnea compared to untreated mild to moderate sleep apnea, untreated severe sleep apnea, and treated severe apnea were followed for 10 years. And the endpoints of the study were MI, stroke, a need for a CABG or need for other coronary angioplasty, and the treated severe group, again, looked just like the group that didn't have sleep apnea, whereas the untreated severe group had an odds ratio almost 3 times for any of those endpoints. So although we don't have any knowledge of what it means to diagnose and treat them in the perioperative world, it shouldn't be that much different from identifying and treating it at any other time in their lives, and the sooner we can diagnose it, the better. So I answered this question, does treating sleep apnea perioperatively improve long-term health outcomes? I say probably, because I don't have a specific study to cite that says it does, but I think it's fair to think that it probably does help long-term. That's the motivation. That's why we want to do this, because we have a risk factor that we have that's modifiable in a way we can improve both short and long-term health outcomes. So the question then is, how do we accomplish this? Is it feasible? And that's the second half of the talk on the how portion. So let's talk about what a perioperative sleep clinic workflow would look like. Patient arrives in perioperative sleep clinic and gets screened for sleep apnea. Those at high risk get referred for formal sleep testing. Those with sleep apnea will get prescribed their CPAPs. Patient will receive the CPAP and bring it on the day of surgery. The surgical team is notified about the diagnosis and the need for treatment. The patient follows up after surgery to assess the adherence and efficacy of CPAP treatment. And all of this can be done right out of the perioperative sleep clinic. Then the patient is transitioned for long-term follow-up, and that can be to a provider, and we'll talk about where they go after they're done in the perioperative space. So if you're interested in developing this type of a clinic in your institution, first thing to do is identify the stakeholders. And there are a lot of stakeholders when you start to do this. And you break it down, you realize that anesthesia is involved in this, the surgeons, nursing staff, and then sleep medicine. At Duke, sleep medicine is predominantly in neurology, but many of you might have institutions where pulmonary runs the sleep department, or it could be psychiatry. Some places it could even be anesthesia, because anesthesia is one of the primary boards for sleep medicine also. So you have to know who you're dealing with in the sleep medicine world. And then the administration, that's hospital administration, sleep lab administration, and your clinic administration, all of which are involved in this. And then in the outside world, who's providing the sleep study equipment and who's providing the CPAP. So they're outside of your institution stakeholders as well. But that's not really feasible. You don't really want all of those people at the table with you. So you're going to want to sort of pare it down to the people who can actually help you make the decisions. And so you can see here I have anesthesia, sleep medicine, finance, and administration really need a seat at the table as you're working on this project. And I left surgeons out, and I did that intentionally simply because, as far as I can tell, if we're not holding up the surgery and we're improving surgical outcomes, that's really all the surgeons need to know about this. And we'll take care of it for them on our end, as long as we're not interfering. And when we get this streamlined, it really does not interfere in anything they're going to do. So in preparation for developing this type of a clinic, the first thing you need to know is what you're currently doing. What is current practice with regard to sleep apnea screening in your institution? If you're not screening, you have to start. That's the first step. Start screening. And the reason you need to screen for sleep apnea before is because it's going to help you determine how many patients you're dealing with. And the volume of patients is going to actually influence a lot of the downstream decisions you make. So if you are screening, you determine the volume, and then from there, you have to find out, where are we going to do this? Is your sleep apnea clinic going to live administratively within sleep or within anesthesia? Is this a peri-op clinic itself, or is a referral being made to the sleep clinic to take care of it there? Is this a hospital-based clinic or an outpatient clinic? There are financial ramifications to that, both administratively and financially. And then literally a space issue. You've got to know how much space this is going to take. So a lot of clinics, especially at Duke, are full. We don't have extra rooms to devote to extra clinics on site. So we have to figure out, how are we going to set this up? And then how is it going to integrate with pre-anesthesia clinics? And what you're going to see is I'm going to keep asking these questions, because I can't prescribe a method for you to do this, only the questions to ask at your institution, because there is no right or wrong, it's just what works for you. So other questions to answer for the team. Who's going to run this? Is this going to be through the nurse practitioners and physician's assistants, or is this an MD level clinic for you? At Duke, we've decided to make this an APP, Advanced Practice Provider Clinic, and that's because our perioperative clinic is already run that way. So we're going to make use of the existing framework as opposed to adding more physicians to this process. Then within that group of APPs, the question is, are they all going to get trained in sleep management, or is it going to be a subset? And how are we going to divvy up the workload between the two groups? We've decided to do a hybrid. So at Duke, we want to use everybody to do the screening, and then a certain portion will become, say, we call them super users or super sleep trained, and they can handle the problems as they arise that are specific to sleep. So we're going to do a hybrid model. And then anesthesia versus sleep medicine. Where does this live? We've set our clinic in anesthesia because that's where the perioperative world usually takes place. The next question to answer is, what kind of threshold? So once you start doing the screening, and let's say you decide to use the stop baying questionnaire like we're doing, stop baying is a 0 to 8. And your sensitivity and specificity is going to change based on where you set the threshold. Are you going to test everybody with a 2, a 3, a 6? And so you have to choose between sensitivity and specificity on this. And if you set your threshold too low, you're going to end up testing a lot of people who don't really have sleep apnea. If you set your threshold too high, you're going to miss too many. There's no right answer to that. You just have to balance what works and what you can feasibly do in terms of screening. And again, that gets back to studying how many are coming through with each level of risk that you determined in your preparatory work. When we talk about sleep apnea, we usually use the measure of AHI, Apnea Hypopnea Index. That's a measure of the severity of sleep apnea and how frequently people are having obstructions when they sleep. In the sleep apnea world, an AHI of 15 or above is an automatic indication for treatment with CPAP. That's moderate to severe sleep apnea, and they all need CPAP because of the medical complications if we don't treat it. But in the 5 to 15 range, that's mild sleep apnea. And the data is not very clear that we can actually improve a lot of outcomes by aggressively treating 5 to 15. So in your institution, you have to set a threshold. At how aggressive are we going to be? Are we going to treat all the 5s, the 10s? Where do we draw the line? Usually the guideline on that is symptoms. If a patient is in the 5 to 15 range and symptomatic, they're tired, their spouses are complaining, or whatever the symptom might be, then it's probably worth treating because you can make them feel better. So regardless of the health outcomes, you're improving quality of life, and that's worthwhile too. So we usually use symptoms as our guide in that mild to moderate range. One of the biggest hurdles in this field is logistics, because you may have experienced in your institution that if you need help from a sleep doctor or trying to order a sleep study, it's months of waiting. So at Duke, for example, it can take 2 months to get a sleep study. So what are you going to do when your patient is there and they're having surgery in 2 weeks and you know you want to get them a CPAP, but you can't possibly get them in the sleep lab because there's a 2-month wait. So one of the questions to answer is how can you expedite this process for them? And the first thing to talk about is using home sleep apnea testing. In a patient who is high risk for sleep apnea, home sleep apnea testing is perfectly adequate and accepted by the American Academy of Sleep Medicine as a diagnostic tool for sleep apnea. Now, it won't catch other sleep disorders. In-lab polysomnography is recommended if you're looking for other sleep problems. But if your goal in the perioperative world is to diagnose and treat sleep apnea, home sleep apnea testing is perfectly adequate. And you don't need to rely on your sleep clinic to do this because you can actually acquire these devices and run them right out of your perioperative clinic. The other alternative is to get your lab to hold beds for you. And that can work also. But that's a much more difficult process if you're trying to figure out how many beds you need held on any given day. Sleep studies, especially home sleep tests, come with auto-scoring functions. So you can choose. If you really want to expedite this, you can auto-score. And we don't do that at Duke. Our decision is that we don't trust it enough. But it might be useful if you're just trying to expedite the process enough to figure out, is this person going the CPAP route or not? You can at least get the ball rolling based on the auto-scoring function of the devices themselves. And the next question logistically is, if you've got a big enough sleep clinic, you're going to need physicians to interpret these sleep studies. And so you've got to quickly process a whole bunch of studies, and that's going to take physician support for them from the interpretation side.
Top Med Talk.
Now, don't forget, of course, the Top Med Talk back catalogue is available for you to download in full at the moment. If you get yourself onto your podcatcher or go to the website, you can download the entire back catalogue of all of the podcasts that Top Med Talk has ever done. We recommend you do that as soon as possible because we're in the process of categorising that back catalogue and it may not always be in its current form. So I'd download it all if I were you, and I'd do that right now. topmedtalk.com or go to your podcatcher. Also, while you're at it, don't forget to subscribe to Top Med Talk and find us on your favourite social media provider. We're on Twitter, we're on Instagram, we're on Facebook, we're on them all. We've even got a YouTube channel. Go out and find Top Med Talk on the internet and subscribe in whatever form you can. It really helps us if you do that. Also, of course, don't forget you can meet the Top Med Talk team by checking out our meetings, EBPOM.org/meetings. Our next big event is EBPOM-USA, Dallas Masters course, a Perioperative Care Practicum. That's on March the 22nd through to the 24th. EBPOM.org/meetings.